Trumble for tonight's talk.
Thank you, Kathy. Can you guys hear me okay? I think I'm just going to sort of stand over here and talk a little bit. So last year when we did this, we did what I called Chiari 101, talking about Chiari basics. I'm going to assume when I'm doing this talk a certain level of knowledge. Truthfully, most of you guys know more about Chiari than most physicians know about Chiari. And so this is Chiari 202, if you will. Some general statistics. 3 to 5% of the population is walking around with some degree of cerebellar tonsillar ectopia. Again, how do we define Chiari? That's something that has changed during my career and will probably change again. Remember, for most MRIs, we're doing 5-millimeter cuts. The accuracy of an MRI is only about 1 millimeter, so using a single number is a very inaccurate way of trying to diagnose Chiari. So 3 to 5% of the population is walking around with some degree of cerebellar tonsillar ectopia. Of those patients, about 80% do not need surgical intervention. So the only treatment for Chiari, because it's an anatomical abnormality, is surgery. But we really don't care about the anatomy as much as we care about the symptoms. How is the patient doing and what's going on? So 80% of patients with Chiari don't need surgery. Of the 80% who have surgery, 80% do fine with their first operation. All right, so we are sitting here talking about the secondary issues. 20% of patients with Chiari operations who have complications. This study came out about a year ago now. Looks at the surgical complication rate. This came out, was actually using national data. So one of the advantages we're having now, I'm going to get very technical, but we used to use ICD 8 and 9 codes when we coded national statistics. Now we're ICD 10. It's the first grouping where we've had Chiari 1 malformation as a specific diagnosis. So it allows us to pull that out, assuming that the physician appropriately codes for the patient. So in this, on the left, surgical complications, you can see with the immediately after surgery, complication rate is at about 8%, and then within 60 days, you're at about 20%. And that's because a lot of patients their CSF leaks don't get picked up right away. So a lot of the times we don't see that. Medical complications, much lower. Medical complications is in the 5 to 7% range. But again, 20% of patients with a Chiari operation have some kind of complication. So why does it matter? We're talking about an elective operation. Very few patients have to have the operation. Chiari is really more of a life-altering, more than life-threatening issue. There are some times where we look at the MRI and we say, oh my goodness, this person needs an operation. You've got a big syrinx, you've got signal changes in the spinal cord, you have craniocervical instability. But for the vast majority of patients, this is an elective procedure, which makes it all the more difficult to decide you want to have a piece of your skull taken off for the operation. And that's why we really need to be paying attention to complications as well. As compared to, say, brain tumors, if you have a brain tumor, you don't have a choice about whether you're going to have the operation or not. You're having the operation. If you have a Chiari, it comes down to how much is the symptoms affecting you. So again, this is just general Chiari information. The important thing from my standpoint, let me see, I've got a little, most of us know the foramen magnum here, Chiari coming down here, this is the Chiari 1 malformation. The analogy I often use is a cork in a bottle, and so symptoms can get tighter, worse when that gets tighter, when the cork gets tighter. Black is fluid here, so the spinal fluid is made in the lateral ventricles. Fluid fills space in the middle of the brain, circulates down the 3rd to the 4th ventricle, where it's supposed to go outside the spinal cord. What the Chiari does is block the flow of spinal fluid, function as a cork, and force the spinal fluid into the center of the spinal cord, causing a syrinx. So these are comorbid conditions. We want to figure out whether patients have them before we do the operation. And I'll take these one at a time. But hydrocephalus, syringomyelia, tethered cord, central sleep apnea, dysphasia. So hydrocephalus literally is waterhead in Greek. And it's the most common thing that a pediatric neurosurgeon does. So if we look nationally, 50% of all pediatric neurosurgical cases are shunts, are drainage of spinal fluid. That's almost always in children, young children. But pediatric neurosurgery didn't exist as a subspecialty until shunts came into existence. Shunts first came into existence by Dr. Holter, who was not a physician, but a PhD in engineering, who had a son in the 50s who developed hydrocephalus. He created the first shunts. I've got some shunts here. We'll pass around and talk about that a little bit. But the diagnosis for hydrocephalus is radiographic. So hydrocephalus means the fluid is building up. So you do typically an MRI, but a CAT scan, or in children an ultrasound will show that as well. Treatment for true hydrocephalus is CSF drainage. So it's a ventriculoperitoneal shunt. About 95% of shunts implanted in the US are ventriculoperitoneal. Spinal fluid comes from the blood, goes back to the blood. For Chiari patients, it is usually obstructive hydrocephalus. You're blocking the flow of spinal fluid. So in order to drain the spinal fluid out, you need to get the spinal fluid in an alternative pathway, literally shunting it out of the brain somewhere else. In the case of a peritoneal shunt, you're draining the spinal fluid from the head into the peritoneal cavity, floating around near the intestines. You'll hear people say it's in the stomach. It's not really in the organ that's the stomach, but it's in the bread box if you want to use colloquial terms. There, though, the extraspinal fluid is absorbed by veins on the inside of the intestines. On the outside of the intestines, just like extraspinal fluid is absorbed by veins on the inside of the intestines. Most of these things we're going to talk about, you want to diagnose before the surgery is done. So for sort of simple concept, if the pressure is up in the head, you have one hole in the skull that stuff can be pushed out of, and that's the foramen magnum at the base of the skull. So if you have elevated intracranial pressure, in this case from hydrocephalus, we're going to talk about idiopathic intracranial hypertension next, and you do a Chiari decompression without treating the hydrocephalus, all you've done is give the brain more space to be pushed down. So you're guaranteeing failure for a Chiari decompression. And then because the pressure is up, you're significantly increasing the risk of a spinal fluid leak as well. So hydrocephalus is important to diagnose preoperatively, as is idiopathic intracranial hypertension. You'll hear the old term pseudotumor cerebri. Pseudotumor cerebri was used because when you look in the back of the eye, you see papilledema, you see swelling behind the eye. That looks like you have a tumor. It's what we see in patients with tumors, but you don't really have a tumor. So pseudotumor cerebri is the pre-MRI era terminology. Idiopathic intracranial hypertension is the current terminology. In those patients, virtually everybody, by definition, because it's idiopathic, we don't know why it occurs, and the MRI is normal, or at least doesn't show fluid buildup. It can show a Chiari, it can show some subtle changes, empty cella, things like that. So the only way to really check pressure is to access the spinal fluid. So that's either drilling a hole in the head and putting a tube directly into the brain, or doing a spinal tap. And so we do a spinal tap on almost everybody. A little bit of fluid drainage has not been shown to exacerbate Chiari symptoms. So a little bit is not bad. We don't want long-term drainage, so something like an LP shunt is contraindicated in the Chiari patient population. For idiopathic intracranial hypertension, if you have that, again, it's idiopathic, so we don't know exactly what's going on, but we know it's more common in females, and we know it's more common in heavier females. So if we look statistically, 50% of these patients will, if the BMI drops below 25, their idiopathic intracranial hypertension will go away, probably related to venous pressure, but again, something that we're still working on right now. So some places, like the Cleveland Clinic, are doing bariatric operations, doing gastric banding in an effort to try to minimize putting shunts in patients, and we'll talk about shunts for a minute, but shunts are not risk-free either. The frustration is the complication rate of gastric banding is pretty high as well, and so you get caught between a rock and a hard place. And I just have discussions with patients and give them options. But virtually, there's nobody in the state who's doing gastric banding. We all do shunts, and the truth is almost all the complicated hydrocephalus patients locally are sent to me, because the adult guys will do 5 to 10 shunts a year. I'll do 5 to 10 shunts every other week. So it is by far the most common thing that we do. Again, same idea with idiopathic intracranial hypertension. If you have it and you don't diagnose it, your pressure is increased, you do the decompression, you're more likely to have further cerebrotonsillar ectopia, and you are more likely to have a spinal fluid leak because you have additional pressure going against the stitches that we put on the dura at the time. So there's about 100 different types of shunts, which simply tells you that we don't have the right answer. I mentioned about 95% of shunts are ventricular peritoneal shunts. For hydrocephalus, we've got a big target. Usually the ventricles occupy 5 to 10% of the intracranial space in adults. In hydrocephalics, it's usually 30 to 50%. So we have a ventricular catheter that we're passing into the brain, has about 1 centimeter of holes at the tip, which is where the spinal fluid comes out. My hand is where the skull would be. This is what's called a Rickham reservoir. It's the same self-sealing silastic that a port would have, for instance, so we can tap it if we need to. And then a valve, so we can set pressure on patients if we need to. This is just a different company. This is Codman. This is Medtronic. They all have at least one connection. I try to use the fewest connections possible, so that both of these styles have one connection. This is orange because it has antibiotics in it, rifampin and clindamycin, to minimize the risk of infection. This is more old school. It's a standard one. The risk of infection in adults is pretty low. It's about 1 to 2%. In kids, it's 8 to 10%, usually because we're putting it in younger kids who don't have a mature immune system. So we put these into kids who are literally 1 kilo in weight, so very small kids if we need to. I'll pass these around if you're interested. Just keep them moving around. Just to give you an idea of medical economics, I hate talking about that stuff, and I avoid it as much as possible, but they don't let me play with too many of those, because that one with antibiotics is about a $4,000 piece of plastic, and that one without is about a $3,000 piece of plastic. And those aren't programmable shunts, so you can program a shunt as well, and that roughly doubles the cost of a shunt. So we talked about this a little bit last year, but about 20% of Chiari patients will have some spinal cord anomaly. So I don't operate on any of my Chiari patients without a full spine MRI to make sure we're not missing anything. The most common spinal cord anomalies are a syrinx, again, fluid buildup in the spinal cord, or a tethered cord. And the kinds of tethered cord is a fatty filum terminale. The filum terminale is the last nerve to leave the central nervous system. We think it went to our tails when we had tails 1 million years ago. It's the appendix of the central nervous system now. It doesn't do anything, but because it's the last nerve made, and embryologically the skin and the central nervous system come from the same series of cells, if a cell that was meant to get to the surface didn't make it, it can get stuck in the filum terminale. The fat does not stretch to the same degree that normal nerves do, and so you're tethering, you're literally pulling down the spinal cord. And again, if you're pulling down the spinal cord and you pull down the cerebellar tonsils and you don't know that that exists and you do a decompression, what's going to happen? You're pulling everything down, you're increasing the risk of failure again. Diastematomyelia is much less common, but it's literally a duplicated spinal cord, often with a bony spicule going through. So that's tethered, it's stuck there. And a dermal tract, so a lot of patients will have cutaneous stigmata. It's why when I see patients, I look at the top of their spine, bottom of their head, and the top of their gluteal crease, their butt crack. So those are the places you're going to most commonly see cutaneous stigmata. Cutaneous stigmata, again, evidence that the skin wasn't made normally there, and if the skin wasn't made normally, it increases the risk that the spinal cord was not made normally there. I've had many families come in who have suboccipital hemangiomas. It's usually just above the hairline, so you need to look. It's easier for me to see intraoperatively because I shave a little bit intraoperatively. And they'll say, well, it's the Williams family stork bite, but it's a cutaneous stigmata for a Chiari. And so many families will have that. Probably 80 to 90% of the patients I operate on have some kind of cutaneous stigmata back there. So, syringomyelia. We've talked about, does size matter in terms of Chiari? Size does matter in terms of syringomyelia. We are using syringomyelia as a term now, particularly the radiologists, for any bit of fluid you can see in the middle of the spinal cord. Again, remember, embryologically, spinal cord starts as a series of flat cells and rounds out. In the middle, there is a central canal, which you can see. So if you do an anatomy dissection of a spinal cord and you cut it down the middle, there is literally a little epithelialized, a little normal area that holds spinal fluid, and our MRIs are so sensitive we can see that now. So again, we're seeing that a lot. We have had discussions about how you define a syrinx, but clearly anything less than 3 millimeters we don't consider pathological. Anything more than 5 millimeters, and we're talking diameter. So I'll often have people call me and say, well, I've got a 3 centimeter syrinx. A 3 centimeter syrinx means that they're measuring the length, and if it's a millimeter thick, it means nothing. If it's 5 millimeters thick, it means a lot. So these are, again, things we need to look at radiographically. We talked about very few things that we look at the MRI and say, oh my goodness, this person's going to need an operation. A big syrinx is a ticking time bomb. So those are the patients that we always recommend surgery on. Certainly if it's greater than 5 millimeters, we talk about doing a decompression. Chiari decompression is successful more than 80% of the time in these patients. We're talking about failure, complication rates in difficult patients. So if you do the Chiari decompression, again, we talked about in most patients, the single Chiari decompression is successful about 80% of the time. That's true in Chiari patients, in syringomyelia patients as well. Some literature will say 85%, some literature will say 90%, but at a minimum 80% chance. But at a minimum 80% chance of stability or reduction in size of the syrinx. These are somebody that you can't assess the syrinx without doing serial MRIs. So I routinely do an MRI 3 months post-op, but whether you do it 3 months or 6 months is personal preference of the physician. You need to do something. If symptoms persist or the Chiari or the syrinx continues to grow, you have failed with your decompression. And so then you need to decide, what do you do next? A repeat decompression, this is the setting in which I use a Cine MRI. Cine, you're looking for flow through that area. So the reason a syrinx decompression may fail is because you have scar that is blocking the outflow of spinal fluid. And the Cine MRI is looking at flow through that area. So this is the setting in which I like doing a Cine MRI. The frustration is if you see blockage of flow on a post-op Cine MRI, the treatment option is then going back and trying to break up the scar, but now your success rate has dropped to 50% because we don't have anything that guarantees breaking up that scar is going to prevent the scar from coming back. There are different products we've used, but nothing has been shown to create statistical significance with that. The traditional treatment for a syrinx, so when I was training in the 90s, before we completely understood that Chiari decompression would help a syrinx, the traditional treatment is a shunt which drains the fluid out of the spinal cord to somewhere else. Remember, the spinal fluid is supposed to be outside the spinal cord. That's the subarachnoid space. So the shunt that I usually do if we need to do a shunt is a syringo-subarachnoid shunt. It's just a little stint, about a 1 or 2 inch length of the tubing, the shunt tubing you have there. And the syringo shunt is a little bit smaller, but it's similar to that. And I drain it into the subarachnoid space. The frustration is you're getting the fluid out, but you're really not preventing it from going back in. So what you're doing is just creating a different flow tract for the spinal fluid there. And you're running the risk of injury. So now we're talking about life-altering issues, potentially big issues. So a syrinx, it's a little hard to see on this, but this is somebody with a Chiari coming down. Black is spinal fluid, and here you see a syrinx occupying 60 to 70% of the spinal cord space. So what do you have to do to get a shunt into a syrinx? You need to go in the middle of the spinal cord. And so going into the middle of the spinal cord is not a risk-free procedure. And so that's why we try to avoid these if at all possible. I probably do 1 or 2 syrinx shunts a year, as opposed to over 100 ventriculoperitoneal shunts. Again, we try to avoid them, and that's why even though the failure rate's 50%, I usually recommend a redo decompression because you're working around the brain, not in the brain. So the risk of neurological injury with the Chiari decompression should be very low. Tethered cord. This picture is showing, this is fat underneath the skin. This is fat that's called a lipomyelomeningocele. So this is a very large abnormality there, but they can be any size. Most of us picture our spinal cord going all the way down to our tailbone. Our spinal cord actually ends just below the ribs, usually at L1-2, and which is called the conus medullaris. And then the rest of the spinal nerves go down in the cauda equina. In Latin, that means horse's tail, and when we open it up, that's literally what it looks like. It looks like a horse's tail or string of spaghetti. And so, again, if there's an abnormality there, fat is the most common thing, but if there's an abnormality there that's tethering the spinal cord, you need to treat the spinal cord tethering before you treat the Chiari or anything else. A radiographically visible abnormality tethering the spinal cord is what we see in the vast majority of patients. The complicating factor is there will be some patients who have an occult tethered cord. Occult meaning we don't see anything on the MRI, but they may have a low-lying conus, they may have something else going on. I never decompress those patients unless there is another indication. So there were some institutions that were untethering everybody who have since lost their neurosurgeons because they were untethering too many. It is a difficult balancing act to have. Most of my occult tethered cords, we look for some other cause as well. So these patients may have lower nerve dysfunction, they may have bowel and bladder dysfunction. We'll often do VCUGs or urodynamics looking for a neurogenic bladder, and if they have a neurogenic bladder, then we know that cutting the filum terminale is a safe procedure. The filum terminale, again, is something it's like taking out your appendix. We can cut it and there is no long-term consequences to that, but it's another operation on you, and if it's not going to do you any good, we obviously don't want to do it. We've talked about syrinx, tethered cord, a couple of things that we look at that we say this is, if you have this, you need an operation. The other thing that we look at is central sleep apnea. So, you know, you guys are all on the online stuff. You know a lot of these. You see the patient who died from Chiari, the patient who had issues. I can say I've never had any of my patients with Chiari die from their Chiari. But when Chiari patients die, they die of central sleep apnea. And they die of central sleep apnea because you're having pressure on the spinal cord where the Chiari is coming down. You are forgetting to breathe. If you stop breathing, you don't live a long time. So you can do, the diagnostic test of choice is a sleep study. That's done by a pulmonologist, and the sleep study can differentiate between obstructive sleep apnea, what heavy people like me get, where you just have too much tissue blocking you, or central sleep apnea coming from the brain, in which case you look for an anatomical cause, and the Chiari is the most common cause of central sleep apnea. They can tell the difference on a sleep study. So if we have central sleep apnea, this is one of the things we'll see in kids often. Central sleep apnea plus Chiari equals operation. the other thing that we'll see, a lot of patients have dysphasia, difficulty swallowing. Again, the cranial nerves which are being affected are the lower cranial nerves, your tongue, oromotor function, and breathing. Those all come down lower. I've had a number of patients, kids, who come in who have such feeding problems that they've had a G-tube already. Before they get the MRI shows a Chiari. We do the Chiari decompression. They never needed the G-tube. So as we are getting to know more and more, we are imaging more of these patients, more of these kids. Adults may have dysphagia, but it's usually not so severe that they're not able to swallow anything. You would have been caught a lot earlier if that was causing problems. But if a patient is having unremitting swallowing difficulties and GI can't find another cause, we usually do an MRI. If we see a Chiari, we decompress them, and it's successful. I actually haven't had a patient that we did that on that ended up needing a G-tube. So that's successful close to 100% of the time. Those of you who have come to me have heard my little spiel on connective tissue disorders. 10 years ago, we called everybody with pain that we couldn't figure out the cause of it, patients with fibromyalgia. Now the trendy diagnosis is EDS. It is my firm belief, and this is now getting into the art of medicine and away from the science of medicine. It is my firm belief that there is a connective tissue component to most, if not all, patients with Chiari. It is also my belief that now we've got 4 types of EDS, but that's really a clinical diagnosis. So it is my belief that we're going to further refine that diagnosis and try to figure out even more what's going on with the connective tissue disorders. The reality is I treat all of my Chiari patients as though they have a connective tissue disorder. And I'm not aggressive in the workup of EDS because whether you have the word hung on your diagnosis or not, the treatment is the same. So the people who do the treatment are rheumatologists. I'm very liberal in my referral to rheumatology. I have been very frustrated in my success in treatment of EDS, and so I have no issue sending patients to rheumatology. I've never had it make a darn bit of difference on any patient we sent to them. So that's just been my experience. And again, you treat everybody, I treat everybody as though they have a connective tissue disorder. Again, that affects a couple of things. Probably why the Chiari is there in the first place. It affects healing. It affects the incidence of spinal fluid leaks. And then the other issues. So these are secondary diagnoses that we were looking for before doing surgery. Now, if we've made the jump, we're going to do surgery, what complications do we worry about? Well, with any operation, there's a risk of bleeding and infection. The risk of infection is low, less than 1%, but not 0. For every operation, people get antibiotics preoperatively. Then most of us give antibiotics for the first 24 hours post-op. But the only antibiotics that have been shown to really matter are those given before incision. The risk of bleeding, so in the adult world, we'll usually check blood work, make sure that your hemoglobin and hematocrit is okay, make sure that your clotting factors are okay, make sure that everything else is okay, in order to minimize the risk of bleeding. And again, the risk of bleeding, such as UD blood or blood products, is less than 1%. Failure to improve, we're going to go through these a little bit more in detail. Failure to improve is the big frustration. So even in the best circumstances, if you check off every box and you have everything that we see on the MRI, the failure rate is going to be 15 to 20%. And it would be nice if we could get that failure rate down to 0, but we haven't gotten there yet. Spinal fluid leak is the most common surgical complication. So when that first slide I showed you had that 20% rate of complication, about 15% of that was a spinal fluid leak. Spinal fluid leak is much more common in the Chiari patient population for a couple of reasons. The primary reason is the dura which usually has a texture similar to skin, holds the stitch pretty well, has been thinned. The reason we're going in there is because there's chronic pressure in there. So sort of like water on a stone, the dura gets thinned. And so it's common that a stitch pulls out. If a stitch pulls out and there's a significant spinal fluid leak, we need to go back in and put another stitch in. If all we do is put another stitch in, there's no reason to think it's any better than we did it the first time. We're not going to finish until we're satisfied the first time. So in addition to putting a stitch in, we put a lumbar drain in. A lumbar drain is literally the same for those who have had epidural anesthesia, literally the same catheter that we use for epidural anesthesia, except instead of giving medicine in the epidural space, we go through the dura and drain spinal fluid out. Most patients who have a Chiari operation hurt and are nauseated post-op, and so that nausea, when you're retching, you're giving yourself a Valsalva maneuver, you're increasing your intracranial pressure, and you're testing those stitches that we just put in the back of the head. And so if we have a lumbar drain, spinal fluid is coming out that drain rather than testing the stitches that we put in. So that's the logic there. Bony regrowth, very rare. I just reviewed our data. So the issue there is you need to make a big enough hole, 2.5 centimeter or 2.5 centimeter suboccipital decompression is what we usually do. We need to make a big enough hole so that the bone doesn't grow back. The body's natural tendency is to close a hole that wasn't there in the first place. So the issue in kids is you sometimes can't get a big enough hole. In our hands, that bony regrowth doesn't happen much past the age of 2. So in the under 2-year-olds, we have 50 to 70% incidence of repeat operation. The over 2-year-olds, that risk is close to 0. So again, this is just what I was talking about there. Why is younger more difficult? We talked a little bit about EDS, idiopathic intracranial hypertension, craniovertebral instability. Craniovertebral instability, as long as you don't go out too far, you should not cause any instability. Now, remember, what's helping stabilize the head to the neck is ligamentous. Ligamentous is soft tissue. If you have a connective tissue disorder, you are at higher risk for craniocervical instability. And so that's something that we really need dynamic images on. Usually we want to move the patients, flex and extend them, rather than do a static picture where they're just in one position. So again, if you fail to improve, what do we do? I really like the Cine MRI in the post-op setting more than I do the pre-op setting. It's fine in the pre-op setting. If you have obstructive flow, it actually increases the chance that you're going to improve with surgery. But most patients, the decision for surgery is based on symptoms. The frustration for post-op patients who fail to improve is that you may have ongoing obstruction to flow that we just can't see. The scar is often the arachnoid. Arachnoid comes from the word arachne, a spider web in Greek. And so it's a tissue paper thin membrane that we may not see. And so if we can't see it on the MRI, we can still look for an obstruction of flow on the MRI. That's the advantage of the Cine MRI. So we talked about re-exploration in that setting. Again, lots of different kinds of shunts that you can put in. I really try to avoid shunting a syrinx if you can. Like I said, I do it once or twice a year. And it depends where the syrinx is, but of course the Chiari is occipitocervical. So if your syrinx starts mid-cervical, you hope that the syrinx goes down into the thoracic and is one continuous hole. You can have septations, and so not everything drains at the same time. But you want to try to get out of the cervical spine if you can when you're doing a shunt, because if you're in the cervical spine, not only are you talking about injury potentially to arm function, but to breathing function as well if you're up at C3, 4, 5. So significant damage in that patient population if possible. Again, we try to avoid it. The last syringo subarachnoid shunt I did was actually a young lady who had a spinal cord tumor, so she was a different patient population, and she was neurologically devastated by the tumor years ago and was just having chronic pain. So in that case, we drained her and helped her out, but she had minimal function below that. So the size of the catheter is 2 or 3 millimeters. We talked about not caring much if the syrinx is under 3 millimeters. Part of that reason is we can't do much to make things smaller than 3 millimeters. In the old days when we shunted everybody, 3 millimeters was considered the best outcome we could get because the tube was that size. So neurological injury. We throw these terms around. You're talking to the brain surgeon. This really isn't brain surgery we're doing. We're working around the brain, not in the brain. The only time we touch brain tissue during a Chiari decompression is the cerebellar tonsils as they are outside of the foramen magnum. And that tissue is dysfunctional tissue. So I used to say that the risk of neurological damage from a Chiari operation is 0. I have a patient who had a cerebellar stroke after this in a location away from where we did the operation, which made it all the more frustrating. And so there is a risk of stroke with every operation. We don't think it's any different in the Chiari patient population than in others, but that is a risk. And it's a risk that is rare, but can occur. Again, probably not related to the Chiari itself, but related to the anesthesia and everything else. So those risks are of concern. The other risks is, so the other times we go into the brain is with shunts. So we talked about hydrocephalus, idiopathic intracranial hypertension. Study came out about 9 or 10 months ago now that looked at the incidence of hemorrhage in the pediatric population. So this is pediatric, but we think it corresponds with the adult world as well. The reason pediatric was used is just because we do a lot more in kids than we do in adults. So again, hydrocephalus is just more common in kids. And this was not the Chiari patient population. This was the shunted patient population. We don't have any data on the Chiari shunted patient population because that's just too small numbers. But remember what we're doing with the shunt. So who has the ventricular catheter? So this part is all underneath the skin until it goes into the peritoneal cavity. This is the part we put into the head. And so we have to drill a hole in anybody over the age of 1. In little ones, we use their soft spots. But in anybody over the age of 1, we drill a hole, usually about the size of my pinky, and pass the catheter blindly into the brain. It is soft. It is meant to minimize the risk of hurting the brain, but this is where I worry about more. And we've had a couple of patients. Our incidence is about 1 or 2%, but if we look nationally, these are national numbers, 10% of patients with catheter placement have some bleed. Not all of them are clinically significant. And then when we remove it, so if it's been in there for a while, tissue tends to grow in to these little holes. And removing it, we literally take this stylet again, put it down the center and cauterize it. So we try to get any tissue that's grown in there out of it. But if we have to take it out, we have more than double the risk of hurting the brain when we do it. So 21.9% in that patient population. So again, this is why we try as much as possible to get everybody into that 80% that doesn't have the complication rate. We're looking through the audience. Some of you guys are that 20%. And I don't say that lightly. I say we want to try to get everybody into that 80% as much as we can. Well, we're doing more research. We're trying to figure out how to get there. We are, by no means are we perfect. And I don't need to tell you guys that because you're dealing with all the frustrations. So those are the primary complications that we deal with on the Chiari patient population. So again, if that's Chiari 202, if you will, If we look at we've now coned down 3 to 5% of the population. Now 80% don't need it, so we're at 1% of the population don't need an operation. And then 80% do fine after that, so we're at 0.2% of the population. And this is the 0.2% of the population. Obviously, we need more research. We need all of this stuff. So we are working on gathering data just to know where we're going and what's going to be happening. Simple things. I told you shunts are the most common thing that a pediatric neurosurgeon does. Simple things. What does spinal fluid do? Is it good when we drain it out of the head? I don't know. Nobody knows for sure. We drain spinal fluid out. We know if you have too much, it's not good. But we don't really know simple things like what does spinal fluid do. Much less what's exactly the right pressure, and what's the right pressure for you is probably the wrong pressure for the person sitting next to you, and vice versa. So as we move forward, as we gain more data, we will hopefully be able to customize our treatment better. Part of my frustration, and you guys are living through much of it, much of my frustration with neurosurgery as a whole is we are so much better now than we were 30 years ago when, in terms of our technology. Better shunts, better MRIs. But in terms of our biology, we're not much changed at all. So Christopher Reeves, for instance, was hurt in Virginia. I trained in Virginia. I remember us all thinking, you know, he believed he was going to walk again. He obviously didn't. What we do for spinal cord injury now is no different than it was 30 years ago. We haven't been able to figure out how to fix damage that has occurred. And so we're trying to minimize the chance of getting to that damage point. But that's much of the frustration that we all deal with is how we maximize a normal life. And like I said, that's part of the discussion you have to have with the patient. Part of hopefully what we've had with, you guys have had with your doctors, if you've had with me if I'm your physician. And for most of this conversation, it's coming down to the patient and how much their current symptoms are affecting their lives. So I'm going to stay here afterwards. I'll be happy to answer any questions that anybody has. And I'll turn it back over to Kathy.
This lecture will be going up on the CSF website within the next couple weeks, and we'll share it with Doug for your website. Thank you so much for bringing us all together out here. Again, any questions for Dr. Trumble? Any questions about how to raise the proceeding?
Yeah, and if you guys want to do a little Q&A, I'm happy to do it so that it'll go on the website. Then if you just want to ask questions personally afterwards, I'll stay as long as there are people.
I have a couple questions. For Chiari, I am into the music industry, and I'm just like so excited because I can do like a big fundraising thing. And where does this money go? Like when they do the research and stuff, is it go to neurosurgeons like yourself? Does it go to?
I'll defer to Kathy. So the answer is, we all donate our time. People who are doing all of this type of work. It's really for research, and I'll let her talk about that.
Not only the lay community, but physicians and doctors. We have many, many physicians coming to us saying, oh my gosh, Dr. Trumble's work there.
Right.
So much
so just a show of hands, I know you can't show up very well there. How many have seen a couple of docs who didn't know how to spell Chiari or what it was? 100% of you, 100%. Right. And you just haven't seen enough docs yet. Yeah, I mean, I used to get a lot of referrals just because my front desk could say Chiari. Yeah, you know, I mean, it's embarrassing, but true. So we were working on education, but you're right. It has lain fallow for a long time.
So that's one of the big things is let's educate. Research is huge. One of the big projects we're doing right now is this common data elements working with the NIH. So I don't know how much you caught, but the CSF employees and NIH representative and neurosurgeons from around the country have been getting on a phone call every Tuesday for almost 3 years now. And they've developed this crazy book of what's called common data elements. And this is supposed to help clinicians and researchers, like I said, compare apples to apples. Because, I mean, I've heard you guys talk, you can measure all different ways. What if someone has their head back like this? They might have a real long herniation. What if someone has their head down like this? It might be short, that we need to compare apples to apples. Not me. So anyway.
No, you're right. You're right.
Sense, but it's awareness. It's.
We're just in our infancy, though. You're right.
Research.
Well, I'm just like so excited. It was only like a month ago. I have had numerous tests. And by the way, I want to thank you for answering my email. I'm not a patient of yours. I was honored you responded to my email. I lost my neurosurgeon 3 years ago. I had Chiari decompression surgery 10 years ago. And I'm starting to have a lot of symptoms. I get my MRIs next week. And you're talking about these connective tissue diseases. I've been to like 3 rheumatologists. I'm so frustrated with that because if it is a connective tissue issue with inflammation out throughout my body, then how is that detected? Is it from the Chiari? Is it not from the Chiari? Is it autoimmune? Is it, all linked back to this?
Right, so I'll tell you, quite honestly, one of the reasons I became a neurosurgeon, I love the brain. I found neurology diagnostically fascinating and therapeutically frustrating. And so for a neurosurgeon, diagnosis is now simple. We do an MRI, and either you have an anatomical problem or you don't. You may do other imaging, but you have to have an anatomical issue for us to assess it. Now, the reality is, again, gets back though, we don't really care if all of us have 10 millimeters of cerebellar tonsillar ectopia. If we're asymptomatic, it doesn't matter. And so my experience is what you're saying. Rheumatology is not up to par with a lot of the connective tissue issues. And I think part of that is because we don't know how to properly diagnose it. It is my belief that we will find 10 or 20 genetic issues that are coming to the final similar answer. So EDS, it's my belief, and again, this is beyond the science of medicine into the art of medicine, that what we're calling EDS now, just like what we were calling fibromyalgia 10, 15 years ago, is a trash bag diagnosis. We can't figure out what else it is, and so we call it that.
Is this hereditary? My father, when I was 5 years old, he became paralyzed, and we didn't know that was 40 years ago. And I can remember for about 6 months, he could not walk. He was, bedridden for a long time. I became paralyzed. Well, not totally paralyzed, but like one side of my body 10 years ago, when I went to numerous neurosurgeons. I slept sitting up for 2 years until a neurosurgeon found that it was the Chiari, and the decompression did help me. I lost all feeling in my arms and stuff. And my father did the same thing. His was from the waist down. He regained his functions throughout his life, but throughout his life he had a lot of the swollen problems, the visual problems like I did, and he passed away from lung cancer. But I have grandchildren and children now, and I wonder with that.
So I talk about 3 to 5% of the population walking around with some degree of cerebellar tonsillar ectopia. We know if you have a first degree relative, so your parents, your siblings, your kids, you double that risk. So you're at 6 to 10%. Certainly it's probably multifactorial, so we can't say this gene causes that problem, but we know you double the risk. We do not routinely recommend MRIs on patients because if you find something, if they're asymptomatic, you're not going to do anything about it. On the flip side, I have a very low threshold of doing an MRI on a patient with a family member who has a Chiari. So if any of your kids or your grandkids, now grandkids 2 generations, so not as clear there, but I would have a very low threshold of doing an MRI if they have the symptoms. And you want to get them before they're having problems with paralysis or anything like that. So your father may well have had a bad syrinx. That was in the pre-MRI era, so we didn't have a good way of imaging back then.
And you think maybe he regained his function because?
That cord got tighter or less tight. Syrinxes can get bigger or small.
So it's possible he might have.
From what you described, I think it's probable.
I was just going to say, I was told by a neurosurgeon to have a 2 millimeter herniation. That was found after the boys were diagnosed. I'm not symptomatic. So, you know, it's something that we would have never even looked
Right.
at.
And any of us could have it.
Right.
So I don't go looking for a diagnosis if you're not going to do anything. But and particularly in younger kids where they might need anesthesia or sedation or something like that, then the risk is higher than the gain. But if they're symptomatic, I'd have a very low threshold. Symptomatic, any brainstem issues, spinal cord issues, bad headaches.
So if they're not exhibiting what we say are symptoms, why are they still scanning yearly if we're not finding new symptoms? Does that make sense?
So, well, I'll tell you what I do. I scan for a couple years. I don't scan long for an extended period of time. I usually scan for a couple of years. And if it's in kids, we haven't talked about that much, but I throw out the degree of cerebellar tonsillar ectopia in kids. Because if you measure anything, measure their fingers or their toes, everything should get bigger. So if growth is commensurate with the child, in other words, if the cerebellar tonsillar ectopia is at C1 and stays at C1, even if it goes from 3 millimeters to 6 millimeters when the child doubles in height, it's a stable Chiari.
Okay.
So what you're looking for is worsening of the cerebellar tonsillar ectopia. Now, we didn't talk about that too much, but there's 4 different kinds of Chiari. They are distinct anatomical entities. So if you have a Chiari 1, you don't go to a Chiari 2 or 3, but you may have further cerebellar tonsillar ectopia. So in routine screening, I do repeat MRIs, typically at 6, 12, and 24 months, but again, that's personal preference. There's no good science to that. But you're looking for worsening of cerebellar tonsillar ectopia. So if you have a child whose cerebellar tonsillar ectopia goes from C1 to C2, you have to worry about decompression there.
Okay, so if you have growth that doesn't go along with like the growth of the body.
Correct.
Okay.
Correct. So that's why the numbers are a little hard to follow in kids. So you really need to look at the anatomical location.
Grow much.
Well, if it doesn't, if it remains 5 millimeters, choose whatever number you want. If it remains 5 millimeters and the child has doubled in size, then it's essentially occupying half of the space that it was
That makes
before.
sense. I just was curious if we were getting MRIs for no reason.
If you're doing them manually, I would say yes. But again, that's personal preference. We don't have great data.
Yeah, it's just costly if they're not going to do anything. Yeah, it's not cool.
Yeah, I usually screen for about 2 years. And I haven't had, I want to make sure I'm being accurate, but I can't think of anybody I've had come back at later. I've been in town 20 years now, so my patient population is pretty stable. I can't think of anybody who came back 5 years out with symptoms or with worsening cerebral tonsillar ectopia.
You spoke a lot about treating the intracranial hypertension first with Chiari. What if you have a syrinx as well? And so you have surgery, and so you have all these symptoms together. So what would you suggest to do first, with that situation?
So if you have elevated intracranial, you have to document elevated intracranial pressure. All right, so either an ICP monitor, when you talk to the surgeon, I like to drill holes in heads. I'd rather do an LP than, so the LP is pretty straightforward to do. If you have elevated cranial pressure, you want to treat that first because what you're trying to do is change the pressure dynamics. And if you can give normal pressure intracranially, you may be able to literally suck up the tonsils because you're changing the pressure dynamics there and thereby decompress the syrinx.
So you think that would be an adequate treatment for a significant symptom?
Yes, yes. If you do the decompression with true elevated pressure, all you're going to do is succeed in that cerebral tonsillar ectopia being sucked down further.
So you would suggest a treatment of the intracranial pressure first?
From what you're describing, I would always treat intracranial pressure. I would treat anything that's pushing the brain down. Okay, so, well, for instance, I got a call the other day about a 12-year-old girl who had a Chiari. Okay, so they did a cervical spine MRI. She had a brain tumor. All they did was the neck MRI, and we had to look at the head to see. But anything that raises pressure inside the head can push the cerebral tonsils down. And so if all you do is decompress and you still have pressure, all you're going to do is push further down. So you need to change the pressure dynamics first. The frustration with idiopathic intracranial hypertension is the ventricles are small. And so remember I talked about you want a centimeter of fluid. Well, you usually don't have a centimeter of fluid to get the shunt working. So failure rate in shunts is about 50%.
Exactly, I read that.
Yeah.
So, other surgeons will tell you, other surgeons, including what you just said, is that a shunt will usually fail.
A shunt has at least a 50% failure rate.
For everybody.
Yeah.
For idiopathic intracranial
Yes.
hypertension. For regular shunts, actually the national average is Pittsburgh data was 40% of all shunts fail within the first 6 months after they're put in.
So why?
And our hands were about
is
20.
gonna fail?
Because then you redo the shunt and you hope that you fall into that 50% that works at one point.
My son went through a few shunts and.
Yeah. They are imperfect devices.
No, but yes.
That pertains to my question. Okay, if you're in the 50% that it worked, how long do I have till it stops?
No, that's a great question. So idiopathic intracranial, moving you around there.
You're fine.
Idiopathic intracranial hypertension is idiopathic, so we don't know why people get it. We do know that a lot of people outgrow it. Things change. You may lose weight. Your hormonal status may change. We don't know why people get it. Again, we think a lot of the time it's venous hypertension. But many people will outgrow, many idiopathic intracranial hypertension patients will outgrow the need for a shunt. Now, if you're 5 years down the road and you're doing fine and the shunt looks in good position, the neurosurgeon will take credit for the shunt working, but the reality is you may not need it anymore, and we just don't know. The only way to tell at that point would be to pull out the shunt and monitor cranial pressure, and that would be another operation, so we just assume it's the shunt, but we don't really know that.
Okay.
The only time we find that is if the shunt is literally broken. If it's a piece of plastic that breaks, you see it's broken, you know the shunt isn't working, you remain asymptomatic.
Okay, and the question about abdominal pain with shunt, is that common to have
No.
abdominal pain with the
No,
shunt?
the answer is it's very rare, but in the Chiari patient population and people who have connective tissue disorders, it's much more common. So we're meant, these are literally the sizes that we open up. Remember, you've got a couple 100 yards of intestines in your peritoneal cavity. Another foot of tubing should not be a big deal. I'm obviously not that tall a guy, but this is the size we open up. So it's got another 2 feet or something that would be in the peritoneal cavity. And this is meant to be soft. It's pliable. It's not supposed to cause problems. It does. So I do a couple 100 shunts a year, and probably 10 times a year there's people who have issues with it. And it's almost always the pseudotumor patients who are more complicated.
So does it cause like adhesions?
Yes.
Or, okay.
Yeah. Right. There's some issues. So adhesions are scarring in the peritoneal cavity.
How
And
do
yes,
you
it can.
diagnose that? CT scan or?
There's no good way to diagnose that without looking in there.
Then
So a
going
CT
to
would
the
show if you had a pseudocyst, meaning if the spinal fluid itself was trapped. The spinal fluid is supposed to be floating around in the entire intestine, so you're using the entire outside of the wall of the intestines to absorb the spinal fluid. If you have adhesion, so it's just a small pocket, you can see that, but that's pretty rare. Usually it requires a general surgeon to do laparoscopy to look.
Okay.
Yeah, but so I have had a couple patients. The shunt, you can't tack it down somewhere because you can't literally sew it somewhere, but they can shorten it and they can move it to places it doesn't move around as much. So for instance, over the liver and places like that. So there are times when you can shorten it. A lot of times patients will talk about perineal pain.
Is a lot of the pain usually, if the shunt runs down this side, is it usually on that side? Or
Highly
does it matter?
variable, because it's floating around all over, so it's wherever the tip of the shunt is, and the shunt is designed to move, so it's supposed to change position when you change position.
Okay, thank you.
Do you get that pain there a lot?
I do, I get pain right here and right on this side a lot.
Exactly what she said. She's the first person I have ever in my life heard describe the same problems I've been having for 2 years. When I emailed you, I don't know if you remember, I had 3 abdominal ultrasounds from the chest all the way down to the pelvic cavity. And when they did the first one, they pressed so hard that my whole body just went numb, and I had a burning sensation go down my whole body. They thought it was intestinal. They did another abdominal ultrasound. I get that pain she's talking about.
But you don't have a shunt, correct?
No.
Yeah.
And
Yeah.
that's why I wanted to bring that up with the Chiari connective tissue issues, if that could be possible, because we've also ran a CAT scan with contrast and a HIDA scan, checked my liver, did liver blood work, all that come out normal. Can connective tissue issues with the Chiari, can it cause all these?
It can, and certainly the Chiari, because it's affecting all the nerves that's coming down, can do that as well. It's usually not that focal. So when it's that focal, you do look for another cause like the shunt or something.
But when she described that pain,
Yeah.
and that's why I wonder, it's the same kind of pain in here.
It could be.
And
I
they,
have a good question.
Yes. I hope I have a good answer.
I think so too. Okay, well, first of all, if you're unlucky enough to get meningitis and you are healed, say, 6-7 months out, since you're decompression, are there known lasting effects from the meningitis? Is there?
So the short answer is no. The longer answer is because meningitis affects the entire brain, if there are issues, we usually talk about trying to get neuropsychology involved. So when Kathy was talking about brain function issues in patients like with Chiari, there really should not affect cognition or mood or things like that, because this is a cerebellar issue, which is coordination. It's not your ability to think.
Right.
It's not your ability, your mood. On the flip side, certainly chronic pain can cause all of those neuropsych issues. So we are trying to include neuropsych more. Neuropsych does, as opposed to psychology, which is just, what's your mood like? Neuropsych is trying to assess, is there specific brain issues that they need to deal with? It is much more difficult to assess post-operatively if you don't have a comparison to pre-operatively. So there have not been great studies with meningitis. Most of the time there is not a long-term issue, but it does affect the entire brain, so there is a risk. Right, and so we can talk about that, but that's probably worthwhile seeing neuropsychology and letting them try to assess what part of the brain's working better. So we know anatomically things look okay, that doesn't mean functionally everything's okay.
I finally calmed down and looked at it and was like, whoa.
Yes.
What are you on?
But that's the frustration. We can get the anatomy looking fine, and we still don't always get the patient looking fine.
Another question, do you remember that tight band that you cut? Well, she had her Skype and then she grew it back. And she's a scar tissue maker person. There's a chance that could come back again.
Yes. Yes.
Cool.
So what I tried to do was take more of it. So there's an occipital-cervical band between the bottom of the skull and the top of the cervical spine. And we try to cut it, and the more we take out, the less likely it is to grow back. But again, getting back to the connective tissue issue, some people make more scars than others. And yes, there's a chance it could come back, and the frustration is cutting scar does not prevent it from coming back. So we try to take out as much as possible so it has to grow farther, right? But it does. There's no way to keep it from growing.
And then one more, sorry. Chronic nausea. That's probably her biggest complaint. If we can get rid of the nausea, the child will be halfway normal.
Right.
But we cannot get rid of that. And she tries every anti-nausea med that's made.
So,
before I open my eyes in the morning.
right. Again, I'll get back. The anatomy looks fine, but there is probably some brainstem dysfunction going on there. We didn't talk about it here, but there was a Chiari Severity Index that was released about a year ago. I'm sorry?
I read it.
Yes, exactly. So I think it's a very good study, and basically what they said was there's three categories they had for Chiari 1 severity. One was the classic suboccipital headaches. If you had the classic suboccipital headaches, you had a 83% chance that surgery was going to help. If you had diffuse or bifrontal headaches, you dropped that success rate into the mid-60s. And if you had myelopathy means brainstem dysfunction, coordination issues, basically evidence that the spinal cord wasn't working properly, you dropped the surgical success rate to 56%. So the concern there is, even though you don't see an anatomical change, there may be a functional change. There may be some permanent damage to the spinal cord that is occurring, which is below the level of resolution of the MRI. The MRI is the best anatomical study that we have. So that gets back to, you know, you're talking to the surgeon, surgeons like to operate, but in general, that is a study that I use to talk to patients that I have some concern about waiting indefinitely in symptomatic patients, because there may be permanent damage even though we don't see that on the MRI.
That's kind of hard one to swallow. I have to put that out there. There's no grades, you know. So, but when you really break it down and you read it, they're trying to predict the success rate of your surgery.
Correct.
Not really grading your PR.
That's exactly right.
Yeah.
So that's exactly right. So they're talking about symptoms. They're not talking about degree of cerebral tonsillectopia. They're not talking about anything like that. And again, there's lots we don't know. What's exactly the right operation? Do we go intradural, not go intradural? You know, all the stuff we talked about last year. When do we operate? So we talked about some absolutes. You got a big syrinx, you got central sleep apnea, you got craniocervical instability. There's some absolutes. There's a huge gray zone. And in my practice, I have slowly become more concerned that waiting in significantly symptomatic patients leads to a higher permanent complication rate.
Yeah. It took 8 years to even get an MRI.
Yeah.
Because our pediatrician was clueless to even get a referral to a neurologist.
Right.
And then we got the referral and,
Yes.
you know.
Yes. No.
But anyway, so yeah.
So I think that's the best data that we have now. I'd like to say that I had the pixie dust to fix everything in the Disney Pavilion, but I don't.
I just have a quick question.
Yes.
What was your, you're kind of a rare breed, obviously, the Chiari specialist. What was it, and I'm speaking on, because there's obviously not a lot of neurosurgeons that really know about this disease. So, I mean, what was it that sparked your passion in becoming a Chiari specialist?
So the way neurosurgeons train is we do an adult fellowship, an adult residency. So I'm board certified in adult neurosurgery. And then we have the option of doing a fellowship. I did a pediatric neurosurgery fellowship. One of the big national discussions that we've had in neurosurgery since I finished residency in '97 is, what do we do with patients who are graduating from being pediatric to adult? And most neurosurgeons have to go to a different operating room if they're operating on an 8-year-old or a 28-year-old. The fortunate circumstances I have here is I'm in the same OR whether I'm 8, 20, whether the patient is 8, 28, or 88. And so that led me to develop this congenital neurosurgery concept. The truth is I stole it from the cardiac surgeons. They had it before I did. And my hope is it's going to catch on nationally. Right now you're looking at the only director of congenital neurosurgery in the world. But it is my belief that if we break neurosurgery down by disease processes, we get better outcomes. So I do a lot of Chiari, I do a lot of hydrocephalus, I do a lot of tethered cord. On the flip side, if I've got a 14-year-old, 200-pound football player who has a slipped disc, I send him to the adult world because they're doing 5 to 10 slipped discs a week, and I just don't do them anymore. So I think that was answering your question.
It was. I was just curious because I've done my own research. So it's, again, like you just stated, you're you're the big guy.
I'm it with that title. I'm not the only Chiari guy, but I'm it with that title. And again, it's because I'm in a relatively unique situation. You can pick, and if you look at a lot of the other Chiari centers, those are areas where.
You've been to other neurologists, and they're like, Chiari, what?
Yeah,
Yeah,
right.
so that's
Right,
why.
but the actual Chiari centers often will have the same OR. So
Sure.
I use the analogy, if you've got Joe Montana, but the rest of the team is the Bad News Bears, you're not going to have the same outcome. So again, having the same OR team is a huge benefit to a surgeon.
Sure, well said, thank you.
Well, why is it that neurologists refuse to acknowledge the Chiari and want to blame it on all other kind of things?
I don't have an answer to that, and I don't have,
And then our only option is to come see a surgeon. There's no neurologist out there that can help
I mean,
us.
I had, Edward's had some,
It's never
he's
the
had
Chiari
some
that's the
doctors
problem.
blame it on weight,
yeah.
blame it on,
Yeah, it's
you know,
never.
other
Everything but
physical
Chiari,
acting,
like-
but the main source of the problem.
Yeah, and my question, I wanted to ask you, in your experience, is there any correlation with seizure activity in Chiari?
Let me be very specific with that answer. The short answer is no. So true electrographic EEG confirmed seizures is a supratentorial phenomena. Chiari is an infratentorial, so bottom of the brain phenomena. There are many patients who have seizure-like activity that's really spasticity or dysfunction of the spinal cord that looks like a seizure, but isn't an electrical seizure. That can come from Chiari.
Okay, but, so it's seizure-like, but it's not, so it's not
But
actually.
it's not an
actually-
electrical abnormality of the upper portion of the brain.
But it is some sort of activity that is associated with the Chiari.
Yeah, usually brainstem
Does that have a
dysfunction.
typical,
It's
like-
brainstem
Does that
dysfunction.
look like something specific, like 5 minutes, 2 minutes staring, like when you see those typical Chiari?
It usually does
seizures?
not alter mental status. So it's usually difficulty with control of extremities, but still you're aware. So if you are have a staring spell where you're not there, that's less likely to be related to the Chiari.
Like daydreaming?
Well, it could be daydreaming, could be absence seizures is the classic
I
one.
just was, like, because our daughter had grand mal, like, they
Yeah.
obvious, like, 5 minute shaking, turn colors, but I always wondered, like, could they be related to Chiari versus are they seizures? Because when
Right.
we took her off the meds,
So
so that's why I wondered if they looked like something specific.
Well, because I just finished a 5-day EEG, and they said they didn't see anything during it, but but for the last 4 or 5 years, I've been having the absence seizures. You know, that he notices them all the time, and I've had several incidents in the car, so I can't drive anymore because of them. But I also had, about a month and a half ago, I had my first, what we thought might have been a grand mal with the shaking, but I didn't lose consciousness though during that episode.
yeah, so if you're
But I
not.
couldn't respond to him during the entire time, but I could hear him and I was still conscious while it was happening, but it lasted for about 5 minutes. And so that's why, you know, so they haven't taken me off any of the meds. They said, well, we're gonna go ahead and keep you on them, but we're just calling it the psychogenic non-epileptic seizures. And I asked them, I said, well, is it possible that any of this is related to the Chiari, is it has anything to do with brainstem? And then they're like, oh, no, it has absolutely nothing, it can't possibly have anything to do with that. It's all psychological and you need to go to a therapist.
What did you call that activity? Not seizure, but
Spasticity.
spasticity.
Spasticity is when you're real tight of brainstem dysfunction. What you're talking about is really more brainstem dysfunction. So.
And because I asked them, I said, could it possibly be, you know, anything to do with that? Could it be, and, you know, and it was automatically, and the neurologist, you know, was immediately dismissed and, oh no, can't possibly have anything to do with that.
Again, we always look for the easy thing, and the easy thing is, do we see electrical activity or not?
Yeah, and they said, well, and I said, well, I understand it, if it's not, and I'm glad it's not epilepsy, and that's great, I don't need one more thing to add to my list, but, obviously I need to figure out what it is, and, can it be from my other, my other friend, what do I need to attribute this to, and,
And
because
so I would say if you're hitting a dead end with neurology, it's time to get repeat images and come back.
I'm having them in the morning.
Okay.
Quick enough.
That's the right path, right?
Dr. Trumble, is it okay if we
Yes,
wrap up and
yes.
then-
Yeah.
Okay. I thank you, everyone, for coming in. Like Dr. Trumble said.
Thanks for coming, drive safely.
And there's still cake, so
There's still
please
cake.
come.